think when we define bladder preservation, it was historically thought about using a trimodal chemoradiation as it relates to treating muscle-invasive disease. However, I think we now need to recognize that bladder preservation needs to be expanded. We have heard a lot about the new terminology for BCG unresponsive disease. These are patients that are unresponsive to induction BCG, and these are patients that are at the highest risk of progression to, and potentially even development of metastatic disease. So we're now developing novel agents that are instilled into the bladder to help preserve their bladder and to help prevent progression. So this is, by definition, bladder preservation. Additionally, the typical way we think about trimodal chemoradiation is identifying patients that are ideal for systemic chemotherapy that sensitizes to radiation. We're learning a lot more about who are the ideal candidates for this, and as urologists, we are able to identify those that would benefit the most. And then lastly, I think bladder preservation is now being defined as patients that are complete responders to cisplatin-based chemotherapy. And can we identify new ways to preserve their bladders without bringing them to cystectomy? So as we move forward, there is going to be a lot of different ways to define bladder preservation. I think the ideal patient for chemo radiation in the muscle-invasive setting is a patient with small volume disease, and not multifocal disease, patients that are clinical stage T2 on exam, patients that do not have CIS or carcinoma in situ, no evidence of hydronephrosis, and actually have a good functioning bladder. They have to undergo a maximal TURBT to remove all visible tumor. We know that this predicts responsiveness. So if this is a patient that's compliant and willing to undergo this approach with maximal TUR followed by chemotherapy and radiation with long-term surveillance, I think these are patients that I feel very comfortable proceeding with chemoradiation. However, there's still going to be approximately a third of patients that will fail and need a salvage cystectomy. So I think some of the newer approaches are combining chemo with checkpoint molecule-based therapy to help improve upon the efficacy of radiation in order to have more patients with an intact bladder at 5 years. I think these are trials that are currently ongoing and are being designed. I think some of the bigger questions are how do we do this? Do we combine it with chemotherapy with radiation? Do we just use the checkpoint molecule antibody-based therapy alone with radiation? And how do we follow these patients long term? So I think there's a lot to learn, and I think that we're going to learn, we are going to get that information from the upcoming trials.